Well, good morning, everybody. And thank you, Clay, for having me. Obviously, if you look at the lineup this morning, it's either Academy presidents or vice presidents, or some, in Ken's case, both. And in Daryl and Clay's case, secretary treasurers, too. So it's a pretty daunting lineup to be first up talking about real medicine. So the JAK inhibitors are the shiny new objects. And if there was ever time to buckle up and be a doctor, this is it. So everyone stand tall and let's see how we can learn how to use these good drugs together, not be afraid. So there's my boys. Everyone always asks, where are the boys? It's like, yeah, they're at home making fun of me. As you can see, they're pretending to be on the phone. It's a little sideways picture, but they're always making fun of me working. I said, good. Then you guys stay home. I'll go to Vail. So, alrighty. Well, I'm fortunate. I got to work with all the JAK inhibitors who have been out. I've got to work with all the biologics that have been out. Got to see them come from their infancy, and got to see, there they are. Oh.
Hello, Neal,
Bhatia.
Bhatia.
Hello, Neal, Bhatia.
Hello, Neal, Bhatia. Hello, Neal, Bhatia.
That's a sign of working way too much when your kids are making fun of you on a teleconference. So, okay. So there are some good references out there. If you've never met Brett King, he is the architect of JAK inhibitors, nicest guy on the planet, and has written a lot of good work, a lot of good articles out there about the topicals, the drugs in development, and then everything that's approved for us. And not just approved, but also in motion for us, which is great. And you can thank all of the sponsors who are here, for those who brought JAK inhibitors to us, but also those in motion that are coming for other things. And it's a very exciting time for patients who didn't have treatments before. So just a little bit of editorial. What are we doing wrong? Dermatologists are giving the specialty away. You just heard from Mark about how we're on the menu and not at the table a lot. And again, we're afraid of our own shadows in many cases, right? We're giving away testing to allergists. We're afraid of consequence rather than looking forward to outcomes. The same patients we used to give intramuscular steroids in the hip and prednisone tapers all the time, like Halloween candy. Now apparently they're not severe enough for drugs that actually will stop the disease in their tracks. And all we hear about is safety apology tours and everything else. And I'll say a few things this morning that I can't say this afternoon. I envision a day where we should be rotating JAK inhibitors and biologics left and right. You should be putting out the fire with JAK inhibitors, maintaining them on biologics, go back and forth as you need to, and don't be afraid, right? We've been working with labs with isotretinoin, with methotrexate for decades. Why should we be afraid of this? There's no reason whatsoever. And I'll show you the data that, again, substantiates that. But again, like I said yesterday, work on turning off the faucet instead of mopping up the mess. That's what changes outcomes. That's what gets patients to sleep and stop scratching. And that's what makes us look like we're actually doing a little bit better job. But here's the problem. Everyone's afraid of the big bad black box, right? What's in that black box anyway? Well, it's a warning, right? It's like, okay, the yellow card at a soccer game, right? Is that the black box? I don't know. But the question is, everyone likes to use the black box against us, right? Oh, this has a black box. It's like, yeah, so what? Are you going to drop dead tomorrow for the first dose? I hope not. But more importantly, look at the results of the efficacy of these trials. Look at the one-year data of patients who've been on these drugs. And look at the low adverse events of healthy 18-year-olds, healthy 20-year-olds who didn't have MACE events, who didn't have lymphomas, who got better and got their lives back because their itch scratch cycle broke in 3 days or less, right? But again, pharmacists love to use this against us. They love to poison patients against us and say, oh yeah, these are very scary drugs. So here, use cyclosporin instead. It's like, oh yeah, that's not a scary drug. Sure, no problem. So again, they're not criminal alerts. They're not meant to create consequence. They're meant to create awareness, okay? Watch for these. Do a few extra labs. See these patients back a little extra if you need to, but don't be afraid. Don't be afraid to get patients better. And getting patients off of Facebook, like I mentioned yesterday, and Google, that's next to impossible. So got to be prepared and have a good defense and strategy. Again, why are these drugs the ones that get substituted for JAK inhibitors and biologics? Because they're cheap and easy, right? But they're not Th2 drugs. They don't affect the process. They don't affect the same cytokines that make the disease compared to psoriasis, compared to lymphoma, compared to other things that we use these drugs for, right? And there is safety data behind it. The gastroenterologists, rheumatologists, they laugh at us, right? They use these drugs like water. And they look at us like, we're so afraid of our own shadow. They're like, we'll take your patients on, no problem. So again, all of these metabolic issues, all these safety concerns, it's up to us. We have to be the ones in charge of it, and we have to be the ones who own it. Otherwise, we're going to continue to be, pimple poppers, and we're not going to be able to do our job. And again, the costs, everyone's concerned about costs. What are the costs of not treating patients? What are the costs of patients not sleeping, not being able to concentrate on their school or work, missing school and work, not having a life, basically, right? Because they're covered in whatever disease that we're trying to fix. So the cost of not treating patients has to be considered just as much as the cost of treating patients. And again, that's why we do these surveys. We do the poems and the HADs and DLQI. They should be part of our clinic notes, like I mentioned yesterday. Have these patients fill them out in the waiting room. Put them into your clinic notes and add them to the severity of your evaluation and management, right? That is all part of the subjective, but that's also part of emphasizing the need for approaching, these diseases with some severity, with some efficacy. All right, so what's superior, right? If you think you're going to get me up here to say, use this drug, it's the only drug you should ever use, you're crazy, right? Because that's not going to happen. But we have all of these drugs in the last couple of years that have all hit the market. Some have been on the market before. Obviously, upadacitinib has been on the market for decades, or not decades, but for a longer time with some other indications. Dupilumab is branching out into other indications as well. Ruxolitinib was an oncology drug, which is now a topical. And of course, tralokinumab and abrocitinib are pretty new, right? Again, the efficacy is based on the demonstration of mechanism. If you understand the mechanism, you understand where they work, the speed at which they work, and how long to keep these patients on, but also how often to see them back, right? Sometimes they're good on autopilot until something happens. So I love this chart because it makes people very dizzy. But this is a good example of all the different dosage strategies. If you start over here, you go from A all the way around to Z. I don't know why they started at 3 o'clock, but I said, okay, that's fine. But these are all the things that are coming. Again, a lot of different approaches. You have anti-OX40, you have anti-TSLP, you have a couple antihistaminergic pathways, all of these other things that are all in motion, then lemolizumab, which is IL-31. Eventually, we're going to have a whole buffet of these drugs that we can use to our advantage. But again, which one first and which one last? I mean, that's the question, right? And again, in the promotional setting, we can't sit there and say, use combination therapies. But what's wrong with starting patients on JAK inhibitors, transitioning them over to biologics for the long run? What's wrong with starting them on biologics and then using JAK inhibitors for breakthrough, like we did with steroids? What's wrong with using JAK inhibitors alone? What's wrong with using biologics alone? Nothing. It's the approach you take. It's the patient preference, right? As I said before, there are shot people and there are pill people. You got to work with them and see what's their compliance, what's their frequency, and even more so, what's going to treat breakthrough and what do we switch to if we have to, right? That's just the logical way of thinking, just like with anything else. And all these patients, all these studies, all the patients were using topical steroids or something in between for breakthrough also. So that's the way we should be treating them, right? And these patients didn't get anti-itch lotions or anything else in between, but we can give them that, speeds up their NRS improvement, speeds up their improvement of their sleep and everything else. So like I said, some patients want pills. It's flexible, it's routine. You can put it on your calendar, put it in your little pill box, and off you go. Small pills are all out there. If you've noticed the pills for abrocitinib and upadacitinib, they're small. Baricitinib's a small pill too. They're easy to swallow, right? And the Sprint, these people stop itching within days, if not even within hours, right? But some people want shots. They want the flexibility of every 2 weeks or a month, and they want things that don't have labs or side effects from what they see. Again, you just talk to them and figure out what's the plan, what's the best thing for them. Other patients are needle phobic and they don't want to go anywhere near it. So again, the sprint may be slower, but the marathon might be faster. So we'll see. I think the jury's still out on a lot of it. So this is all the signaling pathways. The only thing I want you to get from here is that the JAK signaling pathway is independent of 17, independent of NF-kappa beta, which is what steroids use as neurotransmitters, toll-like receptors, as you remember from imiquimod, retinoids, and some of the other antibiotics, and then protein kinase A, which we don't use as much anymore, and then these are more chemotherapy agents, and protein kinase C. So IL-17 doesn't signal through the same pathway. IL-1 and a couple others, they don't use the Janus kinase pathway to process, but most every other cytokine does. Okay, so how do these things work? So work with me slowly, I'll show you. So like I said yesterday, cytokine receptors have to dimerize to bind. The Janus kinase enzyme, if you remember, kinase phosphorylates, donates phosphorus to every step, right? So once that cytokine tries to bind, this dimerizes. The phosphorylation brings the receptor binding, the monomers together. It helps the STAT protein, the signal transducer transcription protein, and then what goes here is another phosphorylation step, which binds the cytokine and brings it down so that the STAT protein can carry that message to the nucleus for transcription to make more inflammation. That's the 4 steps. So when you block Janus kinase, you block phosphorylation of 1, 2, 3, 4 steps. Okay? That's how Janus kinase inhibitors work. Good. I don't hear anybody screaming. That's great. Okay. Now, the nuts and bolts of the STAT protein, signal transducer and activator transcription, is that if it's not able to bind to a dimerized receptor, obviously it can't carry the cytokine, inflammation can't propagate. That's why I keep using that example, stopping the faucet, because you've basically turned off the faucet so that inflammation can't carry over. Now, there's all these pairings, right? And this is, again, the lineup is very unique to some disease states. Like JAK1, we're seeing a lot in Th2 diseases and some autoimmune conditions. JAK1 and JAK3 tend to pair a lot. JAK2 and JAK2 tend to pair a lot. And you guys don't have to take pictures. This is all in your handout. But I can give it to you. So, all you're going to get is blurry images anyway, so who gives a crap? This is all. And then again, the STAT proteins are all unique also. And they have very unique features to what they do with the T cells. And again, even more so, JAK2 and tyrosine kinase 2, and you notice I hate abbreviations, so I spell everything out, is more so, again, linked to psoriasis, IL-12 and 23, which is why the tyrosine kinase 2 drug that's coming, deucravacitinib, will have more of an impact on those pathways. This, again, you see the pairings, but also, again, sometimes they're multiple. And when they're all inhibited, these cytokines tend to fall by the wayside. They don't get to do their job. JAK2, and Dr. Piet knows more about this in his sleep than I would in my, any attempt to study this. That pairing is much more involved in myeloproliferative disorders and hematologic conditions than it is in the skin. And unfortunately, that pairing gets a lot of press because, again, there's saying, oh, well, this is going to suppress your bone marrow if we use these drugs. It's going to stop your blood counts and everything. It's like, no. That's what hematologists, oncologists use these for very specific conditions. So again, these are the JAK inhibitors we have on deck for atopic dermatitis. It's a very exciting time. Obviously, the topical ruxolitinib, upadacitinib, and abrocitinib is, again, they're more JAK1 selective, if you will. Baricitinib the slides are a little outdated. I should have updated it for alopecia areata because that's what it's on the market now. And maybe one day we'll see it for atopic, but I doubt it since lebrikizumab is in the same bag. And then a couple of these have fallen by the wayside. Unfortunately, they didn't make their numbers in trials. So, a lot of topicals could have made it, but they unfortunately didn't make their numbers. So, again, are they safe? Yeah. Get your TB test. Check your lipids at 3 months. If you change the dose, increase it again. Get your immunizations before you start, and then check your CBC at baseline, and then do it again at 4 weeks. Anything bad that's going to happen is going to happen in the first 3 months. So after that, you don't really need to get any labs. You can just kind of follow them. The other important part is, again, we don't use oral ruxolitinib in derm. We don't use tofacitinib in derm. So pancytopenia is something we can watch for, but those events were more from dose elevations as well as the conditions that they were treating. And one of the indications is check for non-melanoma skin cancer. I think dermatologists already do that. But again, maybe something to consider. All right. And again, this was the data from lipid elevations. I won't belabor this, but this was back in the tofacitinib days, which we don't have to worry about too much. But again, anytime you do a dose elevation, you do 15 to 30 with Rinvoq, you do 100 to 200 with abrocitinib, check your blood, check your lipids, and then do it again at 3 months. Okay, this was a nice diagram. Again, I won't belabor the point here. I like this diagram though because again, shows where some specific Th2 cytokines have a link to those enzymes that are in play. Same thing with 31, as we talked about, TSLP, and then IL-22, which I talked about yesterday, significant role in epidermal hyperplasia, as well as, again, propagating other itch cytokines. So I think a lot of those come into play. Topical ruxolitinib is fantastic. And if you want to hear me say fantastic for every drug, I'll say it, because they are fantastic. I mean, look how quickly it works. Look how quickly the itching goes down within days, right? And look how quickly people get better. It works. 1.5% was the winning dose in the 2 studies that matched. The data was pretty good across the board. I think that was a nice thing to see. And again, there was a study for age 12, which is good. Again, this is 4-point improvement in the NRS. This again, we'll see this with the JAK inhibitor family, how quickly the NRS scores got better. And I think that's really one of the differentiating factors between this and steroids, obviously. But even more so, again, you mix this with using biologics and say, okay, I have a lot of opportunity here to put the itching to rest, break the cycle, and put things down. Because the biologics will say, look at our data for 2 weeks, like I said, even better just to have all those options. Nice thing with topical ruxolitinib, not a lot of treatment-emergent adverse events, very little in terms of burning and itching. You're going to have people like that because sensitive skin burns and stings. Whether you're treating rosacea, atopic dermatitis, psoriasis, you're always going to have somebody who says it burns and stings because it's sensitive skin that's probably eroded, lichenified, and excoriated, and it's going to have those consequences. But again, I'll go back and just emphasize, look at that change in the NRS score. I think that's real important to see things improve within days. This is something that I think we should all be aware of. This is the comparison against triamcinolone ointment twice a day, ruxolitinib twice a day. Okay? Look at the milestones of week 2. I'm sorry, they didn't say week 2. Week 2, week 4, and week 8, right? You see the difference here. But why was there not a week 8 arm? Because you can't use triamcinolone for week 8 according to its package insert, right? So you couldn't legally study it against ruxolitinib, which you can use at week 8, which continues to rise. Okay, here's upadacitinib, which again has a very high selectivity for JAK1 over 2. Again, upadacitinib has a rich history, ulcerative colitis, rheumatoid arthritis, psoriatic arthritis. The measure up studies were great. We saw a lot of good EZ90 improvement. Unfortunately, a lot of the package insert stuff, which we see, and Avi's done a good job of explaining it, came from the rheumatoid arthritis population where they were using Janus kinase inhibitors as well as TNF inhibitors and comparison shopping with those. Unfortunately, those patients were a lot of 50 and up, and they had comorbidities. In atopic dermatitis who are 12 and up, we're probably not going to see all that, right? So the safety profile at 15 and 30 is actually pretty good. Even more so, again, they studied a lot of patients with and without topical steroids, and I think that's really, again, we have a lot of opportunities at both the doses. Now, again, they studied both the doses for a reason, so you can learn about 15 and 30. Now, this afternoon, I'll have to behave and say by the rules when you can change by 15 and 30. Right now, I'm going to say do whatever the hell you want. Don't tell Lauren and Brian, they're sitting in the back, but they'll curse me later when I say it the right way. The point of the exercise, again, look at these, again, there's separation between 30 milligrams and 15 milligrams. So again, if somebody is very severe, that's okay to start them at 30 and watch them, and then bring them back down to 15. It's not a crime, but you want to try to watch the safety profile. And again, I start with 15. I have the patients take the first pill in front of me. I have them sit for 20 minutes, make sure nothing goes on. I say, okay, everything good? Then let's go home. Tell me again, call me later in the week. Let me know how you're doing after day 3. Most of the time, they'll say my itching is like 100 times better, right? Most of the time, too, they'll start to say things are improving. I haven't seen this in some time. And again, this goes with abrocitinib. This goes with everything else. All these patients were studied with abrocitinib at all these different doses. Again, they tried to use it twice a day. They looked at some of the other dosage strategies. Again, the nice thing about abrocitinib is it's got a lot of opportunity to use. The renal clearance was good. They did 100 versus 200 in these trials. The problem with abrocitinib is 18 and up versus upadacitinib is 12 and up. So again, the mono trials actually were pretty nicely designed. Again, looking at week 12, they used rescue therapies also. Pretty good clearance in there, just like you saw with upadacitinib. I think, again, it's really a matter of, use your comparison and pick. The JADE Compare study was also with topical steroids at 16 weeks. The JADE regimen was with rescue therapy in the teens. They are studying it for 12 and 18, so we may see something new one day as we go along. I'm just going to go a little faster for the sake of concluding everything, such as baricitinib, which was great. This was the atopic dermatitis study. They did 2 versus 4. They actually had some really good results. And again, very few adverse events in terms of what they saw in the atopic trial, which was great. But I guess we will probably find a better use with getting hair back, which I think is very exciting. So the first time we have a systemic alopecia areata drug in our hands, and the data from this is going to be very exciting. So this is 2 milligrams. We're going to see, let me go just a little faster. Sorry, here's the alopecia areata data. This is the 2 trials that were bringing the drug to the market for alopecia areata, 2 milligrams and 4 milligrams. We're going to see some good dosing strategies. Lilly has a nice display of Olumiant at their booth. Make sure you pay a little attention. This is riclicitinib from Pfizer. This is also under the hood, and we're going to see where this comes out. Again, the trial design is actually pretty interesting, and again, even more so looking at how long we can treat these patients and how satisfactory it is. But just like with baricitinib, the data is very good. It's again a matter of look at these patients who didn't have eyebrows and eyelashes and very severe patches. Think of the steroid atrophy and all the irritation from the patient who were getting treated, and again what they went through, which we can now treat with pills. Lastly, deucravacitinib is going to find its way into lupus, which I think is really exciting. This was data just recently released in Europe, and again, the tyrosine kinase 2 pathway showed itself pairing with some of these other cytokines that were involved with lupus. Again, we saw actually a little bit better with 6 and 12, which is very interesting. But again, they were looking for all that reduction in serology. Again, this is at the 32 weeks here. You see the 3 milligram dose twice a day, actually doing a really good job of controlling the signs and symptoms of lupus, as well as what they call the lupus erythematosus responder index. So again, now we have, again, steroid sparing, but also safer drugs for diseases that we need to treat patients for the long run. So pretty exciting to see when you're looking at some of that. This is something that's in motion. We're going to be doing this trial. It's called rilzabrutinib. Oh my gosh, I'm losing my speech already. And this is called a Bruton tyrosine kinase inhibitor, very different approach, a little bit more efficacy against mast cells and basophils, and we'll have to see where this fits itself into the market. So again, JAK inhibitors are exciting. Don't be afraid. Don't be afraid to use drugs that actually work. Don't be afraid to use drugs that we should keep for ourselves. Don't give the specialty away to those who think they know, because they don't. And even more so, again, don't be afraid of labs. Don't be afraid of watching people. And Clay, you should have your next meeting in Milwaukee, because it's just as pretty. So, very good. Well, thanks, everybody. We'll see you in a little bit.